Hello, good afternoon everyone. I'm Dr. Anaga Joshi. I'm a professor at LPM Medical College and a consultant, ENT consultant at HM Hospital. I'll be speaking on video stroboscopy. So let us begin with our talk. So today I'll be discussing strobe effect, its effect on visualization of the vocal folds and its application in laryngology. If you take a wheel which is moving at a very fast rate, to see with the naked eye, you won't see the individual rotation of the wheel. But if you strike a stroboscopic flashing light at regular intervals, you can see it in a slow motion, moving either forwards or backwards, or still, depending upon the rate of flashing of light. So this, in fact, is a strobe effect. So what is its effect on the vocal folds? Let us see. You all are familiar with the glottal cycle, where subglottic pressure is built up, the vocal folds are spread apart, the pressure is released, and the vocal folds come back together in the center. That completes a glottal cycle. But these vocal folds vibrate so rapidly that it's impossible for the human eye to see the individual movement. The stroboscope allows these vibratory cycles of the vocal folds to be viewed as if they have been slowed down or made standstill. But it does not provide a true slow motion image, as you can see in this video. So what it actually does, these flashes of light flash at a regular interval, so they flash at successive phases or points on consecutive vocal fold waves, and each image is retained on the retina for 0.2 seconds, which is according to Talbot's law. And these images are then fused visually to give you the strobe effect. You require an endoscope camera, a stroboscopic light source, and the endoscope itself, and a microphone which is placed very close to the patient's mouth or over the neck. It picks up the frequency of the patient's sound, and this is fed to the stroboscopic light source, which flashes at a frequency which is close to the frequency of the vocal cord vibration. But what are the drawbacks of stroboscopy? It creates a composite image average over several vibratory cycles. So it can be used only when you have a periodic or vocal cord vibration. And if you have an aperiodicity or very fluctuating frequency, this cannot be visualized in stroboscopy. In fact, it's visualized as fluttering of the vocal cords. And it is a very subjective study, so there can be a bias between different laryngologists. As against high-speed digital imaging, you have the images are recorded at a rate of 2,000 to 5,000 frames per second, which is significantly greater than the vocal cord vibration. And so you get multiple images from a single glottic cycle. This allows for a detailed visualization of the mucosal wave, and it is more effective in diagnosing aperiodic or pathological vocal cord vibrations. Of course, it has a drawback that it is extremely costly, more time consuming, and occupies huge data space. What are the indications for stroboscopy? Stroboscopy actually is part of a routine evaluation, but it is most effective when you have a patient with hoarseness, which is out of proportion to the routine laryngoscopic examination. And in this case, you only
Ganesh Vikas Mandal, Tata Power Line,
have a
Social
very,
Nagar
very
MG
rough
Road,
voice.
सर्वे मुंबई 70 भोपाल.
When we saw his laryngoscopic image, there was a very small, subtle elevation on the left vocal fold, hardly any phonatory gap. But when we switched over to a stroboscopic light, we could see that there is a significant decrease in the mucosal wave on the right side. There is a phonatory gap, and you can see there is the sulcus on the right vocal fold as well as severe scarring. It is also effective to know the depth of the lesion. Here, you can see the case of keratosis. You can see that the lesion is very deep. In fact, it could be even extending to the vocal ligament, producing absence of mucosal base. You can predict the outcome in various vocal surgeries, such as this was the case of vocal fold polyp. You can see a good mucosal wave formation, minimum phonatory gap. So you can prognosticate that patient have a very good surgical outcome. Whereas in this case, you can see that although the polyp is not of a much significant size, there is complete absence of mucosal wave formation and there is the presence of a sulcus. It helps in assessing the postoperative recovery. Here we had a case of a very deep sulcus bilaterally with significant phonatory gap and loss of amplitude and vibration of the vocal folds. A Ponte's technique was performed on this patient, and you can see that there is a significant return of the mucosal wave formation. How do you interpret stroboscopy? So there are various parameters that you need to study: the fundamental frequency, regularity, phase of vibration and symmetry, glottal closure, amplitude of vibration, the mucosal wave propagation, and non-vibrating portions. So fundamental frequency is the first thing that you would record. So in men, it is around 128 cycles per second, and females, it is 225 hertz of cycles per second. A stiff vocal fold will give you a higher fundamental frequency. You can see as this was the case of vocal fold sulcus.
इधर रहते हो? टाइम जरा 1 2 3 4 5 6 7 8.
What is periodicity? It is the cycle to cycle variation. So in a normal vocal fold vibration, there's no cycle to cycle variation, and you can smoothly track the stroboscopic wave formation. But in a hoarse voice, there is irregular vocal fold oscillation, and you can see a jerky motion or sudden changes in the stroboscopy video. So the effective way to know the periodicity or to rule out any cycle to cycle variation is that you set the flash rate at f0, that is same as the frequency of the patient's fundamental frequency. If the cycles are periodic, then you will see a static image or immobile image on the of the vocal cord. But if there is irregularity, it can be various types. It can be either irregularly regular, that is, although it is regular, there can be small irregularity of breaks, which voice breaks, which could is most often due to small a fleck of phlegm which is hitting the vocal cord, or it could be regularly irregular, that is, they are irregular at regular intervals, which is seen in vocal tremors, or irregularly irregular. So the vibration is completely unpredictable, and the stroboscope fails to track any vibration. This occurs in severe scarring or deep sulcus formation. So you can track the regularity by at 0% when it is never regular, or 100% when it is always regular. Phase of vocal fold closure, that is, in the normal modal formation, the open phase is 50 to 60% of the glottal cycle. What do you mean by this exactly? So if you have a glottal cycle and you divide that glottal cycle into 10 equal portions, you will have four frames which show the vocal folds to be in complete contact, that is these two and the last two. Three frames showing the vocal folds to be opening, and three frames which show closing of the vocal folds. So when you have an open fold phase dominant, that is, you see more frames which are open when it is the open phase dominant, which is generally seen in asthenia or glottic insufficiency. Or you have a closed phase dominant where more than two-thirds of the frames are seen as closed. So that generally happens in hyperfunctional voice disorder. Phase symmetry is the degree to which the vocal folds provide mirror images to one another. That is, when they're vibrating, they vibrate with the same amplitude and the same periodicity. So, where in the normal, when both vocal folds open and close together, and the extent of the horizontal expression of both vocal folds is equal. So you can see the amplitude is same and they come together at the same time and go apart at the same time. What is out of phase vibration? That is one when one vocal fold is in the open phase, the other is in the closed or closing phase. Well, you see them in laryngeal lesions such as mass laryngeal lesions, which are because of mass or tension or shape of the vocal folds, or in neurologic lesions affecting the neuromuscular control of the vocal folds, or functional conditions such as muscle tension dysphonia. Here you can see that the left vocal fold is opening while the opposite has not yet opened. And you typically see a snake dance kind of an appearance. The when the right one is opening, the left one is closing, and vice versa. That is, you see the lateral to medial oscillation. Configuration is the shape of the glottis at maximum closure under stroboscopic light. So you can have a normal closure pattern where the vocal folds are in complete contact along the membranous portion. There may be a slight glottic tip posteriorly, which is very common in females, or there can be a mid-chord type of glottic closure, that is incomplete closure at the mid-membranous pole. It's typically seen in presbyphonia or vocal fold scarring or paresis. Or you can have anterior gaps, or which can be either spindle shaped or elliptical, typically seen in sulcus or vocal fold scarring. Midfold gaps are seen in vocal fold nodules. They can be symmetrical in nodules or asymmetrical when you have a polyp and a corresponding contralateral reactive nodule. So you can have an irregular closure when you have either a cancerous lesion or leukoplakia of papillomas, or posterior gaps in muscle tension dysphonia. A significant posterior gap, which is not only just the arytenoid, but also involving the posterior one-third of the membranous episodes. Or you can have completely incomplete gap when the vocal folds never come in contact, such as vocal fold paralysis. So these are the various glottic closure patterns. You can record them in your chart. Amplitude of the vocal fold oscillation is the lateral displacement of the vocal fold during the glottal cycle, and it is generally driven by the subglottic pressure. So in a normal modal phonation, approximately one half to two-thirds of the width of the membranous vocal fold gets lateralized. So in the loud phonation, the degree of lateral movement could be greater, and you get a decreased amplitude when the vocal fold length is smaller, as in children or females, or when there is a laryngeal bed, or when there is increased vocal fold tension, as in hyperfunction, or reduced pliability of the tissue, such as in vocal fold sulcus, or increased vocal mass, such as edema or any kind of mass lesion. So this is, you can see a decrease in the amplitude when there is a lesion on the left vocal fold, or and this was the case of scarring. You can see the absolutely decrease in the amplitude of the vocal fold motion. There are certain pathological conditions leading to increased amplitude of vibration, where if this is seen when there is a muscle, laryngeal muscle tone is very low. The vocal folds are seen as if like a flag fluttering in the wind. So mucosal wave, coming to mucosal wave, it is a wave motion of the mucosal cover traveling along both the vertical and horizontal planes of the vocal fold. So it is indicator of the pliability of the superficial layer of the lamina propria. And in normal habitual phonatory conditions, you would see that the wave travels across the vertical plane of the vocal fold and goes laterally at least 50% of the width of the vocal cord. You can see that I hope you appreciate the mucosal wave here. So if you increase the loudness, the mucosal wave will be accentuated. If the mucosal wave decreases with increase in the pitch of phonation. So you can rate the mucosal wave as 0 when no traveling wave is observed, 1 when there is a restricted mucosal wave, 2 is a normal mucosal wave, or 3 is when there is a large mucosal wave which runs from the glottis margin till the almost lateral portion of the lateralmost portion of the vocal cord. You can have a decreased mucosal wave in or absent mucosal wave in vocal fold scarring or sulcus vocalis. This was the case of vocal fold pit, which is not so visible on the stroboscope, but which is visible on the direct microlaryngoscopic evaluation. What is the importance of a low pitch, loud task? So in cases when you have a slight stiffness of the vocal cord, increasing the loudness will result in a better movement. Whereas if you have a severe stiffness, increasing loudness will not make any difference in the mucosal wave or the amplitude. And certain subglottic lesions are better visualized when you have give loudness task to the patient, because it exaggerates the normal phase difference between the upper and the lower lip of the vocal cord. Let us see typical patterns of vibration of the routine lesions, the normal lesions that we see. So vocal fold cysts, you see anterior and posterior gaps, anterior and posterior to the lesion. The vibratory patterns of the two vocal folds are asymmetrical, and you can see a diminution in amplitude on the affected side. There is decrease in the mucosal wave, sometimes absent mucosal wave, and it's typically seen like a boy in the buoy bobbing along the waves in the sea. Okay. And this pattern's absence or decrease in the mucosal wave differentiates it from a nodule or a polyp. Vocal fold nodules give an hourglass closure. You can have gaps anterior and posterior to the lesion. Mucosal wave may be present over the polyp itself, depending upon the physical consistency. Vocal nodules, you have a hourglass phonatory gap, which is symmetrical. They are you typically find them at the junction of the anterior and the middle third of the vocal fold. And the mucosal wave is present bilaterally, though there may be a decrease in the amplitude or the vibratory pattern on both the sides. Sulcus vocalis, we have seen this video, it's seen as a furrow which is running across the membranous part of the vocal fold. The glottic closure is incomplete and spindle shaped, and there is a focal interruption of the mucosal wave at the site of the lesion. Sometimes, in case of pits, focal pits, there may be absence of mucosal wave at that particular site. Vibratory patterns are asymmetrical between the two cords, between the two sides. So to conclude, stroboscopy detects early lesions and you can determine the depth of the lesions. It differentiates the function and the subtle structural abnormalities of the larynx, determines the changes which are not visible to the unaided eye, such as non-vibrating segments of the vocal cord, or subtle changes in the stiffness, which may be resulting from the from papilloma or scar tissue or laryngeal laryngeal cancerous lesions. And you can compare the pre and post treatment vocal cord vibratory pattern. So to conclude, I thank you, the organizers of this conference, and wish you a very, very happy further days of the conference.